compounds in the grapefruit juice will be inhibitors of that metabolic enzyme. And then in the last, well, the last 20 years especially, but starting in the 60s, we started to see very distinct groups of people responding differently to drugs. This was some patients given this drug called isoniazid in, I think it was 1960. And they found two distinct groups, one group here and one group here, that were metabolizing the drug at a different rate. This is another study. They looked at 1,000 people looking at the metabolism of a drug called the Beazely, and found that some people didn't metabolize it at all, or very, very poorly, very, very slowly. Some people metabolized it so fast that they could barely detect it in the body. And then most people metabolized it, with some variability, as they expected. So why are there these different groups of people? That's because our cytochrome P450 system, from person to person and ethnic group to ethnic group, can vary considerably. So in this case, they're looking at a cytochrome P450 enzyme called 2D6. 2D6, like 3A4, metabolizes a whole bunch of commercially available drugs. And they found out that this is one of the most variable metabolic enzymes. One of the things that 2D6 metabolizes is codeine. Has anyone taken codeine recently? I have, this summer. So codeine actually isn't an active drug at all. Your body metabolizes it into morphine, and then morphine gets into the brain and causes analgesia and all the other effects that opioids do. And that process of converting codeine into morphine is mediated by cytochrome P450 2D6. So what happens if you have very poorly functioning cytochrome P450 2D6? You go to the dentist and get a tooth pulled, and you get Tylenol 3 or some codeine-containing product prescribed. Then you go home and you kind of suffer for a few days because you keep taking these Tylenol 3s and nothing happens. That's because your body isn't converting codeine into morphine, and you're not getting any pain relief. There's acetaminophen in the Tylenol 3s, but you're not getting any pain relief from the codeine. If you go home from the dentist and you take Tylenol 3 and your pain goes away and you get a little sleepy and you feel a little good, but not too much, then you're probably a normal or extensive metabolist. If you go to the dentist and get a tooth pulled and go home and take your Tylenol 3, and you really are on your back in a sort of real sedated, foggy state, then maybe you're an ultra-rapid metabolite, because maybe instead of converting about 10% of the codeine into morphine, like most people do, you've converted 30 or 40% of the codeine into morphine. And now it's basically like taking a triple dose of the codeine. There's actually, this can be a very serious situation. There was an infant that died who was breastfeeding. Their mother was prescribed codeine, a codeine-containing product, and she was an ultra-rapid metabolizer of codeine, so she basically metabolized so much codeine into the morphine that morphine does come up in breast milk and cause respiratory depression and death in the infant. And so there's been you may have seen it in the news, a group of physicians saying, because of this, these differences in the population with respect to 2D6, let's just give morphine. Then we know exactly what we're giving, and we don't have to worry about whether they're a poor metabolizer or an ultra-rapid metabolizer. Then that also brings up the idea of, should we all just go out and get, and find out if we're poor metabolizers or rapid metabolizers or normal metabolizers. And the question is, we probably should, but it's really expensive. There'll come a day pretty soon where that cost has gone down. So if you think of the Human Genome Project, which was this giant multi-million-dollar project to genotype the human genome. Now we've done, I don't know how many different species. And now one person can get their genome sequenced for, I forget what the latest cost was, I think 30,000 might be a number, but I'm not sure. And so eventually, when it's $2.99 at the genotyping store, then it might actually make sense. It might be cost effective to do it. But for now, we're still in an area where we're just, the cost effectiveness of doing it for all patients just isn't there.
So some dentists still prescribe codeine? No.
Codeine is still prescribed very widely. So if you have ever had a codeine prescription and felt that you didn't have an effect or maybe too much of an effect, that might be something to mention. But then there's also the making sure all health practitioners are on top of this really huge field that's there's an immense amount of information that we know about all of these cytochrome P450 enzymes. And to make matters worse, so we've got all these enzymes that are genetically variable from person to person. And to make matters worse, most drugs that we take interact with these cytochrome P450. So let's say you're taking a drug that inhibits cytochrome P450 2D6, and then you take codeine. It'll be just like if you didn't have the 2D6 at all. You won't get any benefit because the enzyme will be turned off, basically, and you won't be able to convert it into more. So that's a whole other, it's a very complex field of drug interactions and genetic variability. So I want to talk next a little bit about the difference between a therapeutic reaction and an adverse reaction. And in the therapeutic reaction, we can also think about, in the case of recreational drugs, whatever high that the user is seeking is the therapeutic reaction. So some therapeutic reactions and adverse reactions are on a continuum. And so I use the example of benzodiazepines or Valium. So if you take a little bit of Valium, you're going to activate a chloride channel in the brain. And one of the first things you're going to see is a decrease in anxiety. And then if you take a little bit more, you see a sedation as you activate more and more of these chloride channels. And then if you take a little bit more, you might go into a coma. And then if you take a little bit more, your respiratory center will get shut down, you'll stop breathing, and then you'll die. But all of these effects, from the good effect to the negative effect of the death, are all in the same continuum. They're all the same mechanism of action. And then other times we can have different mechanisms of action. And that's when you have a beneficial effect that you want, but the drug is interacting with another system and causing the adverse effect. And one of these is an older group of antidepressants called tricyclic antidepressants that give their benefit from increasing the amount of serotonin in the synapse by blocking serotonin transporters. But they cause all sorts of adverse effects because they block all sorts of other receptors. And when Prozac came along, which was the first in this new class of antidepressants, their claim to fame wasn't that they were better antidepressants, it was that they were more selective antidepressants. So they were a little bit different. They did kind of the same thing as the tricyclics, but they didn't have all of these non-specific effects, and so they didn't cause as many side effects. So the ideal drug has one effect, and it's beneficial, and it's got a big therapeutic window. And then you can have all sorts of unexpected reactions. Some of these are allergic reactions, some of these are just unexpected reactions that, for many of them, we don't have good explanations for. So that's a little bit about the basics of how drugs interact with the body. And the next thing I wanted to do was to talk about just a couple of recreational drugs and what their mechanisms are, what their molecular pharmacology is. So there's two important disciplines, I guess, when you're thinking about any drugs, including recreational drugs, and how they're going to act with the body. One is pharmacokinetics, and that's really what the body is doing to the drug. So what the body is doing to absorb the drug, where the drug is going once it gets absorbed, how the body is metabolizing the drug, and how the body is excreting the drug. And then the other is what the drug is doing to the body. So which receptors or protein targets is that drug going to interact with? And I think we've gone through these definitions already. Efficacy, how well do the drugs work, potency, the therapeutic window, toxic versus effective concentrations, and agonist and antagonist. I think I've used those terms as well, activators or inhibitors of different receptors. This was in American Scientist. There's been a couple couple other interesting graphs like this. This is the ratio of the fatal dose. So how much do you need at one time to kill yourself, to overdose and die, versus how much you need for effective dose. Because we're talking about recreational drugs. This is the effective dose means achieving some sort of high. So you've got some at the top that have enormous safety windows. Again, this is on acute dose, acute once dosing. So marijuana, it might be difficult to ingest enough to actually overdose. And LSD as well has a huge therapeutic window. Psilocybin or magic mushroom is up there as well. It's got a very large therapeutic window. Just for example, here's alcohol at 10. So alcohol, it's difficult to drink yourself to death in one sitting. Usually you pass out beforehand. You need to ingest quite a bit, about 10 times as much of alcohol versus how much you need to sort of get a little bit drunk or get drunk. So that gives you an idea of what we're talking about. So that's still a pretty big therapeutic window. You can drink a lot and not die from an acute ingestion of alcohol, although it is possible. Heroin is one of the most dangerous with respect to an acute dosing. The amount you need to get high versus the amount it causes the respiratory depression is relatively narrow. And then there's all sorts of stuff in between. Nitrous oxide, which is laughing gas. A lot of these are hallucinogens on the top end. Here's codeine and ecstasy, cocaine. They're all around alcohol. Dextromethorphan is actually an interesting, it's a cough suppressant. Most of us take it in cough medicine. It's an opiate, it's related structurally to morphine, but it doesn't have any effect like morphine does, but it does have hallucinatory effects at high doses. And some other ones, nutmeg is down here. And that's why I asked that question. I was talking to you earlier about the LSD versus the anticholinergic. Nutmeg has anticholinergic alkaloids in it, and if you take enough nutmeg, a large dose, you can get hallucinatory effects. But it's also relatively dangerous, because you can see compared to some of these other things.
How come
Yeah.
nutmeg is spiced, no?
Yeah.
That's how that could be?
If you take enough of it, if you shave a little bit onto some hot cocoa or something, you don't see any hallucinatory effect. Or this is talking about how much you need to get a recreational high or a hallucinatory effect versus how much you need to take for.
Why is that then? Like, why is there like some sort of list of prescribed materials?
Well, because usually people don't use nutmeg for recreational purposes because like I asked in that question, there's better options. I mean, Jimson weed, which grows a lot, also has anticholinergic alkaloids, and that is something. And in fact, there was an article in Saskatchewan recently or last summer, I guess, about these 3 young boys that went and made this Jimson weed to try to hallucinate, and they ended up in hospital.
Where would methadone be on this list?
Methadone would be similar to codeine up here. Methadone is I mean, it's an opioid, and you can certainly cause respiratory depression, but they would be around the middle, similar to codeine.
I read some reports in England regarding that they're saying with regard to social policy that I guess mentioned that alcohol is much more dangerous than marijuana. So change the law.
That study, and I should have put it in. So somebody took basically this data and then added onto it the cost to society. So they took the relative safety, the addiction potential, and the cost to society. So job losses, breakdown of family unit, and all the other negative consequences that come with drug addiction. And so they basically combined those 2 sets of data. And so then all of a sudden alcohol and marijuana moved up to the top, not because of their danger necessarily on acute ingestion, but because of their widespread use and all the negative outcomes from alcohol use and marijuana use, basically because they were so widely used.
Do you feel that study, do you feel